We have been doing prevention of periodontitis for over 50 years. Results have been encouraging but incomplete when the efficacious interventions have been deployed in populations. So this workshop offers us the opportunity to regroup, rethink, and put things in a new perspective. So that's really the objective, is look again at what we can improve and hope to achieve a different level of impact in the population, in the European population. It is going to be of fundamental importance in reorienting clinicians, I mean dental hygienists, dentists, periodontists, the whole profession, in making sure that we will do things in a different way. There are a variety of very, very important outcomes of this workshop. The first one is that we need to be really clear that whenever we do preventive measures, people should not have already disease. So prevention is not something that should be done when people already have periodontitis. And this is really an issue. It's something that is a misuse of preventive measures. In many, many countries, what happens in real life is that preventive measures are deployed without a previous diagnosis. So they are deployed simultaneously on people with disease that should be treated and not prevented, and people who are actually in need of prevention to maintain health or avoid degeneration of their condition. So this is, I think, a very, very important difference. The other important difference is that this workshop gives us the opportunity to really focus on what we should be doing. We have identified the fact that professional mechanical plaque removal is actually not something that should be done blindly, and rather it is something that should be part of a strategy of for example, it needs to be combined all the time with oral hygiene instructions. And again, this is something that is very, very important. It's not the procedure itself. And the procedure, the mechanical plaque and calculus removal, is actually something that is important in making sure that people can care for themselves through their home care, their routine oral hygiene procedures. In the past, the idea was, well, let's continue to deliver the same message. Now, after this workshop, the message is going to be totally different, because we are now focusing not only on the content, what should people start doing, so what kind of behavioral change they need to achieve, but we are also starting focusing on what is necessary to have them do the behavioral change. And we have developed some very, very useful and practical approaches. One, for example, is what we call GPS. So G is for goal setting, P is for planning, and S is for self-monitoring. What does it mean? It means that every time we want to get somebody to improve their behavioral change, to actually adopt a better way to perform oral hygiene, we need to set very specific goals with the patient. The second thing that is extremely important is the planning. How are you actually going to do this? Exactly how you are going to implement the change in your life. And then it's actually self-monitoring, which means the patient should actually be able to check if he is achieving these goals that we are setting. So these are the three things that research has shown are very important determinants of oral hygiene, of uptake of oral hygiene instructions. So this is a very interesting dimension. So we are bringing psychological theory into everyday preventive measures. So at the end, within this framework, which is the GPS, we have to put content. And content is coming from what type of oral hygiene aids are needed, with which frequency they should be applied, what adjunctive elements can be used in terms of chemical plaque control or other aids. So that's extremely important. Another very, very important issue for clinicians is that we are differentiating. And this is very important. It's done for the first time. What is the content? What is the intervention when it comes to professional mechanical plaque removal in the context of primary prevention? So when we are doing it to the general population of generally healthy people, and when we are delivering something similar to people who have been treated for periodontitis. In the second situation, the treatment changes a little bit. So we call the first PMPR. It means that we're going to remove the biofilm, disperse it from the neck around the teeth, and we extend submarginally as far as it is needed to get to the bottom of the sulcus. We are including removal of plaque and removal of calculus. When we are in the treated periodontitis patient, PMPR becomes PMPR plus. So it's an upscaled version of the intervention that also includes removal of the deposits, dispersion of the biofilm, all the way to the bottom of residual shallow pockets that may still be present in this situation. So it's really tailoring the intervention to the clinical situation. One is primary prevention, the other is secondary prevention.